measurement of endometrial receptivity and what current evidence we have on the different methods that we use for testing the endometrial receptivity. And in the later half, I will be discussing the methods of endometrial preparation before frozen embryo transfer. So, starting with Professor Bob Edwards once said that human endometrium is the last barrier to progress in assisted reproduction technologies. So the key component in any successful embryo implantation are, we know that we need a competent embryo and a receptive endometrium. They need to be in intimate crosstalk with each other. So what is the normal implantation rate in any IVF cycle? So we have a data that only 25% of the transferred embryos actually implant successfully, and maximum success rate even in a PGT tested cycle is only 50% per embryo. So what is the cause of this low success? It was estimated that embryos are responsible in 1/3 of these failures, and inadequate endouterine receptivity has been found to be responsible in 2/3 of the implantation failure. Recently, Leslie and BA, they define endometrial receptivity as that period of endometrial maturation during which the ectoderm of the blastocyst can attach to the endometrial epithelial cells and subsequently proceed to invade the endometrial stroma and vasculature. So the important thing is what actually decides receptivity. For an endometrium to be receptive, it should be normal at the structural level and also should be normal at the functional level. And what decides the structure and the function? So there are certain histological and molecular markers which have to work together in coordinated fashion to give it a normal structure and function. It is dependent upon the sequential action of estrogen and progesterone, and there is a coordination of molecular events. They have to happen in a proper chronological manner. There has to be a particular, what we call as dating in histology. It has to happen in a coordinated manner, one after the another. The shifting of the timing is very important in this. So critical shift in expression of the receptors is very important, and they should both happen synchronously. So just a revision of our old histological aspect of the endometrium. We know that the endometrium has two aspects, glands and stroma, and they, under the influence of estrogen and progesterone, they undergo series of changes, starting from straight, then coiled, then they become bent, then they're subnuclear vacuoles. So these are the transformation that takes place, and according to the earlier criteria, Noyes criteria, they found that this histological maturation is it happens in a very timed fashion, and by doing that timing, that dating, we can actually predict that the endometrial maturation is appropriate for the date or not. So this is a chronology which actually formed the basis of the endometrial receptivity. This was the starting point where the endometrial receptivity actually, the whole idea of endometrial receptivity started. Any problem at the level of formation or the dating of this, if the time period for which these maturation should happen, if they get deranged, then the whole receptivity of the endometrium gets affected. So this has been characterized as histological dating. Now, we have always focused on histological dating. It should always be balanced with, and it should happen in synchrony with molecular dating as well as. So there are certain markers which are very, very, subjected to different phases of the cycle. There is an estrogen phase, there is a progesterone phase. So there are certain molecular markers which are expressed specifically in the estrogenic phase, and there are certain molecular markers which are expressed in the differentiation phase, that is the progesteronic phase. If there is these markers, the shift should happen from these markers to the differentiation phase markers like leukemia inhibitory factor, alpha V, beta 3 integrin, hoxa, ginseng P20. If there is this shift doesn't happen, then we say that the endometrial receptivity is deranged, and both the histological and the molecular dating, they both combine together, they form the endometrial function, and they are responsible for the proper maturity of the endometrium. So a receptive endometrium is characterized by down regulation of estrogen and progesterone receptors. So if we see the proliferation phase, there are certain receptors called estrogen receptors and progesterone receptors. When we move into the differentiation phase, these ER and PR receptors, they should get down regulated. Their expression should stop. Otherwise, the endometrium will remain resistant to estrogen and progesterone hormone, which are released once the corpus luteum is formed. So as I was discussing, there is a condition called estrogen receptor defect. It is characterized by two types, that is unresponsive or inactive endometrial glands even in the presence of adequate or supraphysiological levels of estrogen. So what happens is that the estrogen receptors are there, but they become unresponsive. So even when we give high dose of estrogen, the endometrium stays thin, it stays unresponsive. And another condition, when they become hypersensitive, that means they become highly proliferative even in the absence of exogenous estrogen, and it may result into hyperplasia, polyp, or formation of carcinoma. Similarly, we have progesterone resistance that we commonly see when we give estrogen followed by progesterone. There is luteal phase deficiency happens. This is because the estrogen receptors, they don't get down regulated, which should happen in the differentiation phase. This is because there is certain inflammation leading to increased endometrial aromatase expression and increased estrogen activity. So there has been found that these are some of the receptors like SIRT1 and BCL6. Their levels, these are the mediators of progesterone resistance. These are the markers of progesterone resistance. They are increased in sera as well as the endometrium, and their increased levels is correlated with progesterone resistance. And this condition is commonly seen in patients of endometriosis and unexplained infertility. These markers have been found to have an anti-implantation effect. So these are two images there where we see the first image, which is in normal phase endometrium, the phase B, where there is increased expression of SIRT1 and BCL6, and they indicate if these mediators are present, these patients require higher dose of progesterone to get a proper receptivity in the endometrium. So we discussed the functionality of the endometrium. Coming to the most basic, the structure of the endometrium. It is the most frequently employed indirect predictors of endometrial receptivity. And we know that if in any case that we are planning an embryo transfer, if the endometrial thickness is not optimum, we usually formulate a prognosis for that patient that the chances of that patient becoming pregnant will be on the lower side. So what is actually cutoff for the endometrium thickness? When can we say, we don't have any, cutoff key? We can say that this is the endometrium, which is the receptive endometrium, and in this 100% guarantee of pregnancy is there. So different studies have given different cutoff, and it has been found that it is most of the time age related, with lesser chances seen in the younger women and more in the older patients. So different studies have quoted different endometrial thickness required for the conceptions, even from 4 to 5 mm to minimum of 7 mm. And there are studies which have shown that there are the optimum endometrial thickness for before implantation should be, some studies have quoted 9 to some even 10 to 14 mm. So there is not a clearly defined, there need to be more studies to clearly define the cutoff for a receptive endometrium. And this was a study in which they showed that there are certain changes that take place in the thin endometrium, which affects the receptivity of the endometrium. One of the factor was that the VEGF and beta tubulin expression gets reduced in thin endometrium. The blood flow, the radial artery resistance index increases, and the blood vessel, the area of the glandular epithelium, it decreases in thin endometrium, which affects its receptivity. This study was done by Liu et al. In 2018, and they compared over 40,000 cycles, and they correlated the endometrial thickness with the live birth rate, both in fresh and FET cycles, and they found that live birth rate and clinical pregnancy rate decreased, and pregnancy loss increased with each decline in endometrial thickness below 8 mm. Similarly, in FET cycles, they found that any endometrial thickness below 7 mm was associated with a decreased live birth rate. was a most recent study where 96,000 cycles were studied, and in fresh cycle they found that the pregnancy rates and live birth rate they were increasing with the increased endometrial thickness, although the live birth rate plateaued at around 10 to 12 mm. Similarly, in FET cycles, the live birth rates plateaued after 7 to 10 mm. But the important conclusion from all these studies was that although the pregnancy rate was increasing with the increased endometrial thickness, but the pregnancy rate in the patients, endometrial thickness in patients who got pregnant and in the patients who didn't get pregnant, the endometrial thickness was comparable. There was no significant difference. So in patients who were getting pregnant, as the endometrial thickness was increasing, the pregnancy was increasing. But when it was compared between pregnant and non-pregnant patients, there was no significant difference in the mean endometrial thickness. So this highlighted the fact that not just endometrial thickness not individually alone is responsible for pregnancy. There are other factors also which play a role in deciding for the receptivity and the pregnancy of the patient. So this was their data, and they also concluded that there is no cutoff for endometrial thickness. Earlier studies which proposed that an endometrial thickness of 14 more than 14 was if associated with lower implantation, but they refuted this thought and said that there is no cutoff, and endometrial thickness, the more it is, there are more chances of pregnancies. And now this suggestion has been refuted by several other studies which have been done recently. So apart from the endometrial thickness, what are the other factors that may affect receptivity? There can be endocrine causes like hyperinsulinemia. Obesity has been shown to have negative impact. Inflammatory events like endometritis, adenomyosis, fibroid, polyps, septa, immunological mediated disturbances. So these are some of the factors, molecular markers that we studied. These integrin expression, LIF, leukemia inhibitory factor expression, they get decreased in fibroid, adenomyosis patients, in endometrial polyp patients with hydrosalpinx. In PCOD patients also, it has been seen that hyperinsulinemia can decrease beta-3 integrin expression. Similarly, some mucous myomas can decrease HOXA810 expression and can lead to reduced receptivity. So why do we actually need receptivity markers? Since that histological dating by Noyes criteria started, there has been a lot of advancement. Now we can do embryo screening, we can do PGT, we can select the best embryo. We are moving towards single embryo transfer. But one thing that is keeping us back is, we cannot, similar to the embryo, we cannot actually predict the endometrial receptivity. We don't have any gold standard or any marker which can actually prognosticate the women about their pregnancy rate. We can there is no gold standard or no marker we can use pre-IVF to treat or prevent implantation failure. So there is a need for these receptivity markers. So if we talk about the markers of endometrial receptivity, I have broadly classified them into invasive test and non-invasive test. Non-invasive is the most commonly used, that we use ultrasound, where we check for endometrial thickness, pattern, blood flow, volume, and then a recent concept of compaction has come. And invasive markers, we can go for endometrial biopsy, hysteroscopy, and endometrial fluid aspirate can also be done. Endometrial biopsy, we can test for several markers. ERA is the very prominent one. We'll talk about about the current evidence regarding the use of ERA. Then there are other tests we discuss: histology and cytology, uterine NK cells, molecular markers, BCL6 and SIR1. Then there are inflammatory markers like CD138 and 60S ribosomal RNA marker. So the most commonly used modality for assessing endometrial receptivity is ultrasound, and the common parameters are that we normally see are the same: thickness, pattern, blood flow, 3D endometrial volume, a more advanced version. Then there are endometrial waves and contractions as well. So this was a meta-analysis which was done to compare all the conventional and modern markers of endometrial receptivity, and they found an association between endometrial thickness and pregnancy rate rate, but their ability to predict clinical pregnancy was found poor, and they suggested that it cannot be used as a diagnostic test of endometrial receptivity in clinical practice, because again the same thing, between pregnant and non-pregnant patient there was no significant difference between the endometrial thickness. So with the increasing, and if they took 7 mm as a cutoff for endometrial thickness, and they found an increasing a strength of association with increasing endometrial thickness. The thicker the endometrium was, more favorable was it for the pregnancy. But there was no short endometrial thickness where we could say, okay, at this point the patient is surely going to get pregnant. Then there was another, like Doppler indices. This has been used in several studies where it has been shown that endometrial, subendometrial flow, uterine artery, PI, and more advanced like 3D VI, FI, VFI, that is vascularization index, flow index. So different cutoffs have been taken in different studies. There is a lot of heterogeneity between the multiple studies which have been done, but these are some of the, because it is a non-invasive, or we can say minimally invasive, ultrasound is the most patient favorable test, and the studies have shown that if there is a decreased flow in the endometrial, it can negatively affect the implantation. So we can work on that. PI in a study by Sai and colleagues was suggested that if uterine PI is more than 3, then there are absolutely no pregnancy rates, and uterine endometrial volume should be ideally more than 2 ml. And in a study by Wu et al., they suggested that VFI is more reliable than VI and FI, and it should be more than 0.24. This was also a recent study which confirmed the similar findings, that endometrial blood flow is there is increased chances of implantation and pregnancy rate when the endometrial blood flow was on the higher side. And they found that in patients who conceived, their PI, RI, and SD ratio were much lower compared to the group of patients who didn't conceive following a fresh IVF ET cycle. So this was the data, and they found, although there has been found an association, but there was no clinically significant difference in endometrial thickness. So it cannot be used as a a definite marker for it cannot be used as a gold standard. But more studies are required. Actually, there need to be a clear-cut cutoff for that, and there should be an algorithm on what parameters are we going to study, and more studies are required actually to move to clearly point ultrasound as a marker for endometrial receptivity. So there are lack of RCTs, no established threshold, and the quality of evidence is low to very low, and no consensus could be reached based on endometrial pattern to predict the outcome. Similarly, with Doppler uterine assessment also, there was lack of adequate predictive ability for the IVF outcome. In 3D ultrasound also, multiple studies were done, but there were controversial results of different studies. Some studies using 2.5 ml as the volume, some studies using a 2 ml. So there was a lot of variation between the studies and their outcome. This was a study by Grisingar et al., and they said that endometrial thickness is actually dependent on the age and number of eggs retrieved, and they concluded that it should not be taken as a good predictor of treatment, because it depends upon the embryo quality and the age of the patient. And they concluded that unless the endometrium thickness is very on the extreme side, no treatment should be actually tried to improve the thickness of the lining. This was their conclusion. This another study, they compared 3D ultrasound to the endometrial waves to the endometrial thickness, and they found that endometrial thickness is better, and using 3D ultrasound or subendometrial contractility does not improve the pregnancy rates in the patient. This was a recent study in which Zhang et al. Actually they combined all the parameters and they calculated a score. They used 6 parameters and they gave a score for each parameter. They gave a score of 0, 1, and 2 if the endometrial thickness was less than 8, 8 to 14, or more than 14. And using this parameter, they found that individually these parameters did not lead to any statistical significant difference for pregnancy, but when they combined it and created this endometrial receptivity score, the clinical pregnancy rates were significantly improved. And when the receptivity score reached more than 5, the pregnancy rates were significantly high. So they used thickness, volume, echo of the functional layer of endometrial central echogenic line, endometrial peristalsis, endometrial blood flow, and they combined and made an endometrial receptivity scoring system. This is a recent concept which has come, like endometrial compaction. These authors, Haas et al., they predicted that if on the day of embryo transfer, the endometrial compaction is present, that is the shrinking of the endometrium, then it is associated with a higher pregnancy rate. So they said that the compaction, more were the chances of pregnancies. So if after starting progesterone, the compaction was 5% and or 10% or 15%, 20%, the more the compaction was, more was the ongoing pregnancy rate. But later on, this concept was refuted by other studies, and they found that compaction does not actually predict live birth rate, and it is not a good predictor of reproductive outcome. So we last spoke about endometrial function test. This has been one of the receptivity marker which was suggested by the author Kliman et al. And they suggested that if histological dating is combined with molecular dating, we can fairly predict the maturation status of the endometrium, and we can actually modify our hormonal supplements, and we can treat and manage the endometrial receptivity. So they suggested that the biopsy should be done on 2 days, day 15 and day 24, and the progression of the endometrium should be assessed based on the histological markers as well as the molecular markers. So if on the day 15, that is post ovulation, if we see progesteronic changes in the histology of the endometrium, but it is not correlated with the expression of LIF, B3, HOXA-P27, or we see is that PR, progesterone receptors, MAG receptors, cyclin E are still present on day 24, it predicts that there is a maturation delay. There is a glandular arrest. Although the stroma has progressed, but the glands which express these molecular markers are still lagging behind, and we need to adjust our progesterone levels. We need to adjust the timing of the transfer of the embryo. So this was called as endometrial function test, and they found that an abnormal endometrial function test was 10.5 times less likely to have an ongoing pregnancy rate. But there were limitations to this test. 2 biopsies are required, and it is like time consuming. We need an expert reproductive pathologist, and read-to-read reliability may be a factor in this test. Then coming to a lesser invasive marker called endometrial receptivity marker, endometrial fluid aspirate. So this is again a new concept where we don't actually take biopsy from the endometrial. We just push 1 ml to 2 ml of normal saline inside the endometrium, and we take that flushing and we study it for the molecular biological markers. And there has been several studies done on these. Several markers, receptivity markers, have been studied using immunoassays. And Boomsma Caroline in 2009, he actually studied whether collection of the fluid was safe to it was safe to collect on the day of ET. And and she found that it does not hinder implantation. It can be safely collected, but the major limitation to this test is that the amount of histological material that we get is very low to detect the desired target. And again, the main drawback of these receptivity markers are there is always a variation in the expression of these receptors from cycle to cycle, even in the same patient. So to get a definitive cutoff for these markers is really difficult, and it is very difficult to reproduce the result of these tests. So there have been extensive study done on this. So, and again, there was a lot of heterogeneity in the methodology and the selected biomarkers. So no convincing evidence could be done for a clinical use of these studies. So again, hysteroscopy, it's very commonly used by the reproductive medicine specialist. Can it differentiate receptive from a non-receptive endometrium? Should it be indicated for all women with subfertility undergoing ART? So this was a study done by Santi et al. In 2012, and based on a Masamoto score, which they differentiated a receptive endometrium into good and unreceptive endometrium as poor endometrium based on the type of glandular opening and vascular networks that they saw on the mucosal surface during hysteroscopy. So it was considered as Masamoto good if there was ring time glandular openings. It was considered poor if the glandular openings were punctate type or very sparse. So this was a study which said that if it is good, then the patient had a better chances of pregnancy. And this is another study, with a relatively new study, in which the density of the endometrial glandular openings was studied by using a software. During the hysteroscopy, the video was recorded of the hysteroscopy, and those findings were then later on feeded into a software, and that software actually counted the number of endometrial gland openings that was visible on the endometrial lining, and they found that more dense the endometrial glandular openings were, more in number, more was the chances of live birth rate in the patients. So this was a very interesting study, and it was almost like a computer was actually assessing and counting the number of, but again, it can be, it is a computer, it's a machine, it can actually mistake any other lesions or spots as the glandular opening, and it can give false positive results also. So hysteroscopy also, according to the meta-analysis, data was insufficient to consider it as a gold standard for receptivity marker, but definitely it is a promising tool, and should it be prescribed to all patients before? So this was a Cochrane in 2019, and they said that for a general population, subfertile women, it is not recommended to use routinely or hysteroscopy, but there was a low quality evidence that in patients who are undergoing IVF, preferably those who have undergone like who have already had 2 or more IVF failure, it definitely has a benefit, but the quality of evidence was low. So if we see this forest plot, in this the strength of evidence is lower for patients for first IVF, but yes, for 2 or more IVF failure, there is definitely favors towards hysteroscopy. Coming to ERA, ERA is, we know it uses array analyzes the expression of 238 genes, and it actually identifies a personalized window of implantation. And based on this window of implantation, we characterize the endometrium as receptive, pre-receptive, or post-receptive, and accordingly, your hormonal, your progesterone supplementation is adjusted, and your embryo transfer is adjusted. And again, the testing, if it comes non-receptive, again the testing is done to check whether with the adjustment done, whether the endometrium has now become receptive or or not. If it still comes non-receptive, then some therapeutic intervention is done. So this was like the most controversial and most debated test. It is often asked by patient, often ask, can we, should we go for ERA? We had recurrent IVF failure. Should we move on to ERA? Will it help us? So there has been like a lot of limitations of ERA. It is very expensive. It causes a lot of pain and anxiety for the patient. Then it delays the, your conception cycle. You have to freeze the embryo. You have to, and recently there is a lot of evidence coming up that the ovulatory cycles are better for implantation, for better for perinatal outcome. And it has been found that biopsy results, they vary again from cycle to cycle in the same patient. So there is poor reproducibility between experiments and different groups. So there were studies like by Dr. Arian et al., and they reported that there was no difference in live birth rate or ongoing pregnancy rate between ERA and non-ERA group. And Cozzolini et al., they've actually found that it worsened the outcome in a patient undergoing personalized embryo transfer with ERA. So this was a detailed review by Zion et al., and they concluded that based on the assumption that progesterone manipulation can bridge a 12 to 24-hour window of gap and correct the endometrium without having a gold standard to compare to any of these effects, all with a single tool, namely gene profiling, seems insurmountable. So you are actually predicting that window of implantation is only for, you are adjusting the window of implantation by giving progesterone, manipulating the progesterone, and you are saying that it is very narrow and you can easily adjust it by shifting it or by preponing it by 12 to 24 hours. So this is not what is window of implantation. It actually becomes a point. So tests like ERA, until shaped and proven, should be offered only under research protocols, and that separate compounding factors considering all the above reservations and keeping in mind that freezing embryos is not risk-free. So it is very important that we, in case we are doing ERA for the patient should be appropriately counseled, and patient should be informed about that is not, it can be done only under the research setting. Then coming to uterine NK cell, it became very popular. Uterine NK cell, we know that immune cells play a very important role in implantation, but it is very important to understand the natural killer cells are actually required for implantation. It is when they get unappropriately overactivated or underactivated, it results in pregnancy loss or implantation failures. So just mere when we do biopsy, we see NK cell, it doesn't mean it is bad or harmful. It is actually the most important cell which is required for implantation. So its functionality, when it gets altered, the endometrium turns non-receptive. So it is very important to actually understand the pathology and the other cells that may actually act in conjunction with uterine cell to affect the implantation. So the balance of these receptors is very, very important. These immune cells is very important. When this balance gets disturbed, then the infertility and implantation failure happens. So there were several studies again which were done, and one of the study actually found there was no difference when they compared between women who miscarried and women who achieved live birth rate. Chen et al., they actually found a percentage, because it is very difficult we need to have a number at what percentage it becomes negative, at what percentage it becomes it is actually required. So they calculate a percentage and they found that if fertile controls, it needs to be approximately 2.5%, and when they said the median levels for recurrent miscarriage was 3.2% and recurrent implantation it was 3.1%. So this was a single study which calculated the percentage, and more studies need to be done to actually find out the cutoff. And there is no consensus regarding the method, timing, or reference range, and single biopsy is not always representative of the entire endometrium. So there are a lot of limitation to these studies, and based on the biopsy, we cannot put the patients on unnecessary steroids or immunoglobulins. So they can have their own harmful effects, and if the patient is like having endometritis or hyperinsulinemia, steroids or these medications can actually worsen the condition. So these needs to be studied more. Recently, new markers, as we discussed, BCL6 and SIRDA1 has come. The great thing about these markers is they can actually these are the simplest way to actually diagnose these are the markers of hidden endometriosis, and where the endometrium express these markers, it indicates there is a progesterone resistance. Such patients require higher dose of progesterone for establishment of pregnancy, and these patients need to be treated for endometriosis, and this was a study which was done, and they found that there women with low level of BCL6 expression had a significant higher clinical pregnancy rate compared to women with higher BCL6 expression. And recently this concept has come where it has been found that endometriosis is one of the hidden cause of many implantation failure, because in stage 1, 2 endometriosis are usually undiagnosed on ultrasound as well. And earlier we used to blame oocyte quality as the main reason for endometriosis failure, but recently in a study they found that implantation failure is the most important reason for recurrent implantation failure in endometriosis. So in patients where we find this BCL6 or SIRT1 positive, these patients can be actually helped with the with medical management. In FET cases, we can actually give them agonist long protocol, down-regulated protocol, and in infertile, subfertile patient, laparoscopy can be done, and disease can be identified and treated. This was a test. This was a study which was done in patients of unexplained infertility, and those who came positive for BCL6 when they were treated with medical suppression or laparoscopy, they showed significantly higher live birth rate. So coming to chronic endometritis, another very important cause for implantation failure. This marker, we normally depend upon hysteroscopy findings, micro polyps, presence of plasma cells, strawberry endometrium. So chronic endometritis, many times when we take the biopsy expecting that we will get some plasma cells, we don't usually get the plasma cell positive. So in those patients, if we send the biopsy for immunohistochemistry for CD138, it was found that this was more sensitive than hematoxylin eosin staining to identify the plasma cells. So CD138 is a new marker for, and we should use more and more rather than depending upon histopathology alone. And there is endometrial microbiota is a new player in town. It has been found that women of chronic endometritis and many subfertile women, the endometrium is colonized with the non-lactobacillus bacteria, which can have negative outcome on the reproduction, can cause implantation failure, can cause even miscarriages and pregnancy loss. So this technique called 16S ribosomal RNA targeted PCR NGS can actually detect the lactobacillus dominant from non-lactobacillus dominant growth. This was a study which was done, and they found in chronic endometritis patient, the median abundance of lactobacillus was 1.89% only, and 80.7% were colonized with non-lactobacillus taxa like Gardnerella prevotella. So this is a very important finding, which tells us that patients, along with antibiotic treatment, they also need probiotics to improve their microbiome and improve their receptivity. So after all these markers and evidence, we can actually say that there are multiple markers which are actually involved in the endometrial receptivity. There is no single marker as such, and even if we form a comprehensive prognostic model that may include all the biomarkers, embryo characteristic, hysteroscopy, we may not be able to cover all the factors. So endometrial receptivity is going to remain an enigma. Coming to endometrial preparation, there are like FET, we usually go with the hormone replacement treatment with or without GnRH agonist suppression, true natural cycle where we may or we may not give luteal phase support, then modified natural cycle where we may give HCG support with or without luteal phase support, then mild stimulation with the, so these are some of the methods. Coming to the HRT cycle, what does the evidence says about preparation of endometrium? According to the evidence, estrogen may be administered orally, vaginally, intramuscular or transdermal route, and both natural as well as synthetic estrogens can be used. The evidence says that the type of estrogen and the route of administration usually has no effect on the success rate of FET, and there is no upper limit for the duration of estrogen stimulation. Studies have shown that it can be extended up to 28 to 36 days, but most normal responders usually have adequate priming by 5 to 7 days. But it has been seen that in priming less than 10 days, there are increased rates of miscarriages. And there are two types of regimen that we usually follow: fixed dose or incremental dose. Both of have been shown to have comparable live birth rate. Agonists are usually not recommended because they are added increased cost. There were some studies which showed higher live birth rate, but there no benefit was seen in terms of clinical pregnancy or cancellation rates. Again, progesterone vaginal versus intramuscular, both have been found similar with clinical pregnancy rate. But in one of the studies, they showed the live birth rate was very low, significantly lower in vaginal progesterone only group when compared with IM progesterone. Or vaginal progesterone. So they, in this study, they found that vaginal progesterone only group, the pregnancy rates decrease, but when we combine it with intramuscular progesterone, or we compare it with intramuscular progesterone only, the pregnancy rates were comparable, were higher. So then another study, they found that when vaginal progesterone is combined with oral dihydrosterone 10 milligram twice daily, it showed significantly higher live birth rate and lower miscarriage rate. So as for the current evidence, there has been no difference in vaginal versus IM progesterone, but based on some of these studies, preference should be towards vaginal combined with either oral dihydrosterone or intramuscular progesterone. Timing for the start of progesterone is if we in a HRT cycle, if we consider TOR, that is a theoretical oocyte retrieval day, starting from that day 3 progesterone, day 3 embryo, the progesterone should be given till the day of embryo transfer. Day 3 embryo should be given till the 4th day of total 4 days of progesterone should be given. Day 3 embryo can be transferred on 3rd day of progesterone as well as on the 4th day of progesterone. Similarly, a day 5 embryo can be transferred on 6th day of progesterone as well as on the 5th day of progesterone. But later than that, it can cause asynchrony between embryo and endometrium. So there is a paucity of data on impact of different routes of progesterone. Vaginal administration, most commonly used route. Future studies are required to delineate the optimum dosing of various vaginal forms of progesterone. Day 3 embryo should be transferred day 3 on 3rd or 4th day of progesterone, and blastocyst can be transferred 5th or 6th day of progesterone. Progesterone should be continued till 10 to 12 week of gestation in HRT cycles. A meta-analysis demonstrated that following a fresh embryo, progesterone can be discontinued once a positive pregnancy test is detected. And on starting an HRT cycle on day 2, if the progesterone levels are more than 1.5, it does not have any negative impact on the reproductive outcome. natural cycle where we don't give any medication. We start the monitoring, TVS monitoring from day 8 to day 10. And once the follicle reach 15 daily or alternate day TVS is performed, because the important thing is we don't want to miss the ovulation in this cycle. How to pinpoint the day of ovulation is the evidence recommend that serum LH testing should be preferred over urinary LH testing. And if the rise of LH from the previous values, if it is more than 80%, it indicates ovulation, and it should be accompanied with concomitant rise in progesterone and a fall in estrogen levels. Modified natural cycle to avoid cancellations and to to correctly predict or plan our cycles or embryo transfer. We can pair it with SCG trigger, and the evidence says the lowest effective dose should be used, as it will result in lower early serum progesterone, which should reduce the risk of endometrial advancement, known to have a negative impact on endometrial receptivity. So when we are using SCG for trigger, the lowest levels should be used, because the additional progesterone that is released can actually increase the risk of endometrial advancement. So the day of embryo transfer and role of luteal phase support. So it was found that in natural cycle, luteal support actually helped increase the live birth rate. But in modified natural cycle, where SCG trigger was given, there was the luteal phase support with progesterone was not necessary because of the lutotrophic effect of SCG. So progesterone support after embryo transfer could be optional. So a very important thing is to avoid too early administration of progesterone, because again it can induce embryo endometrium asynchrony. If administered based on available evidence, the luteal phase support should not be started earlier than LH surge plus 3 days. Mild ovarian stimulation using oral agents, clomiphene, letrozole, or exogenous gonadotropin, and when the endometrial thickness is more than 7 mm, E2 levels more than 150. So this was like from a study, it was given that SCG can be administered when the leading follicle is greater than 17 mm. So anywhere where we feel, when we get a optimum endometrial thickness, we can plan for an SCG trigger. And it has been found to improve the pregnancy rate. It improves subtle defects in folliculogenesis and subsequent luteal phase, resulting in a better endometrial milieu for embryo implantation. Common clinical practice normally is to give luteal phase support in mild ovarian stimulation cycles for FET. So which is better, natural cycle, artificial, or stimulated? So when compared to natural cycle, ovarian stimulation with gonadotropins or clomiphene citrate does not enhance live birth rate. When compared to HRD cycles, gonadotropin or letrozole ovarian stimulation have a slightly increased chance for live birth rate. And in a meta-analysis by Wu et al., it was found that artificial, that is HRT cycle, was associated with significantly lower live birth rate compared to true natural cycles. So the best is natural cycle. If we can modify it with the use of SCG trigger, then it is also comparable to natural cycle. Then is our mild stimulated cycle. Last is your HRT cycle. So live birth rate are highest when your cycle is as close to the nature as possible. So the studies have now shown that artificial cycles, HRT cycles, are associated with poor reproductive outcome, so perinatal risk are increased. This is because ovulation is not there. A hormone called relaxin, which is released, is not there. This can result in increased risk of pregnancy-induced hypertension, placental. The placenta is weak. There is increased risk of preterm birth, increased risk of postpartum hemorrhage. Now, this was another study where they found that there was the FET cycles, programmed FET cycles, that is HRD cycles, are at increased risk of cesarean section and postpartum hemorrhage and increased risk of birth weight. So coming to our rescue protocol, many times when we see that the progesterone, there is marked variation in the progesterone levels. Many times after giving progesterone, we see that the progesterone levels are not within the optimum range. Recently, in a study by Yovich et al., they suggested that the mid-luteal progesterone should be between 22 to 31 nanogram per ml. So, based on the evidence, a rescue protocol was suggested. In this, on the day prior to embryo transfer, serum progesterone was done and a cutoff of 10.6 nanogram was taken. So, if our cycles progesterone levels fall below 10.6 nanogram, a rescue additional progesterone of 25 milligrams subcutaneous was given. And when they compared the control group and rescue group, they found the live birth rates were comparable. So other studies have also shown a beneficial results with the rescue protocol. So we in our, especially in obese patient, where the pharmacokinetics may vary and absorption may vary, so we can do progesterone one day prior to our ET cycles. And although this cutoff has been different in different studies, we can take a cutoff of 10.5 or 15, and if it is less than that, we can actually add progesterone to our already running progesterone protocol. So in endometriosis patient, it has already been proven that extended gonadotropin suppression therapy improves the pregnancy rate. So extended GnRH protocol before embryo transfer, it increases the chances of pregnancy. And in PCOS patient, it was found that FET cycles, those where letrozole was used, letrozole stimulated HRT cycles had a lower miscarriage rate. So what are the methods where we can improve the endometrial receptivity? Lifestyle intervention is a must. It has been found that micronutrient deficiency like vitamin A, D, hyperglycemia, obesity, harmful microbiome, these all can affect our endometrial receptivity. So we can work on improving these deficiencies. Sunlight and exercise has also been found to modulate the immune cells in the uterus. Thin endometrium, three ways we can, by increasing the dose, duration, changing the route. Vaginal route has been found to have uterine first pass effect, and we can increase the estrogen concentration reaching the uterus. It has been found that synthetic estrogen have give rise to thicker endometrium. In estrogen receptor defect, if there is unresponsive endometrium, we can change the route and dose. In hyperplastic endometrium, down regulation of pre-progesterone administration can help. This was an article use of adjuvants, and they found there is no role of adjuvants in the management of thin endometrium. In patients with the progesterone resistance, where we see BCL6 and endometriosis patient, in such patients, GnRH agonist treatment or surgical treatment, and even use of letrozole to block aromatase can restore integrin expression. This was a study for improving endometrial receptivity in IVF cycles with or without letrozole, and they found that endometrial integrin expression increased after the use of letrozole concomitantly in the fresh IVF cycles. In patients who are progesterone deficient, these patients are the ones in whom rescue protocol may be required. Patients who are obese, PCOS, endometriosis, advanced age patients who have thyroid dysfunction, hyperprolactinemia. So these patients are the ones who require more progesterone in their luteal phase support. We need to treat the cause for the impaired endometrial receptivity to improve it, like endometriosis, leiomyoma, and hydrosalpinx. Embryo endometrial synchrony is very important. Transfer of the embryo based on the progesterone, the start of progesterone is very important. The day 3 embryo is already discussed, should be on the 3rd day of progesterone or 4th day, and similarly day 5, 5th day to 6th day of progesterone. Scratching has
please wind up kar do.
हो गया मैम, हो गया. So the seed or soil, select the best seed, prepare the soil, and start by doing what's necessary, then do what's possible, and suddenly you're doing the impossible. Thank you.
Thank you. That was quite an exhaustive talk. Now I invite Brigadier Sharma sir for his opinion. Sir, are you there?
Yeah, yeah.
Yes,
Thank you,
yes.
madam. And I must compliment Dr. Nupur for.
Stop presenting, please.
Uh, can you hear me, madam?
No, stop presenting. I was just telling Nupur, stop presenting. Yes.
Okay. To talk about the endometrium in such details, though most of the investigations may still be not feasible in the normal practice, but still at least we should be aware what is the future is going to be. Maybe in times to come we will have a strip test. You just take a small washing from the endometrium and do the strip test and say, oh, this all the factors are there. The color will change, and we know that yes, this is the receptive endometrium. It will come. I'm sure about that. Now,
Likely
the thing,
because-
yeah. Now the problem is sometimes we find that there are two type of uteruses. One is anteverted and having fluid, and after estrogen. A second one is a retroverted uterus having fluid in the cavity after giving estrogen. What is your take on that, and how will you manage? Because that is a quite a common problem which clinicians would face.
Endometrial cavity fluid.
Yeah, because you can't transfer. It's not a.
Endometrial cavity fluid, first we have to find the reason for that. I think when it is a stimulated cycle, patient is a hyper responder. In such patients, when we are stimulating by day 8 or day 10, we normally see fluid, but when we do a scan during progesteronic phase, secretory phase, the fluid usually disappear. But in patients, if the fluid it persists, what we do is we freeze the embryos, and then we give a mild stimulation cycle using letrozole. So estrogen is an androgenic hormone. So higher the estrogen, more the chances of getting fluid in the endometrium. The second that most commonly we look for is hydrosalpinx. Sometimes, the most important thing is there is a hidden hydrosalpinx. Many a times there will be a very thin layer of fluid in the endometrium, and it will be persistent and recurrent. In that case, we look to the older reports of the patient. Many a time, HSG report, they show fimbrial block. Fimbrial block patients with the HSG report, they are the patients who are most likely to have hidden hydrosalpinx. We call it like subclinical hydrosalpinx, which may not actually be visible on ultrasound, and that fluid might actually be entering inside the endometrium and affecting the receptivity of the endometrium. So the second point is to rule out hydrosalpinx, and if hydrosalpinx is present, it needs to be cleared. Third, what we see, fluid in endometrial cavity is inflammation inside the uterus. There is always, in such patients, we need to go for a hysteroscopy. We have to find out there is any, we have to rule out endometritis. We should take biopsy. We do CD138 for all histopathology, culture, CD138, TB-PCR. All these tests are done. And, even if all these factors come negative, because they usually come negative, we give down-regulated protocol. Down-regulate there is a baseline inflammation. That as we said, that hidden endometriosis, hidden inflammation, there will be no infection, but the uterus will be the endometrial lining will be hypervascular. Such patients, what we do is we down-regulate, prolonged down-regulation for 3 months, and then usually the fluid disappears. Even after that, if the fluid doesn't disappear, we aspirate and we do ET.
Would you like to send this fluid for cytology and culture?
Yeah, yes, sir. We do send for culture.
Yeah. And any role of adenomyosis, creating this excessive fluid?
Yes, sir. It is very, very rampant. Adenomyosis is a very, very common diagnosis that we see in our routine practice, and it is one of the most underrated diagnoses, I can say. Many of the patients who have unexplained infertility will have mild to moderate adenomyosis. Everything is fine. Their ovarian reserve is fine. Everything. So adenomyosis also leads to an inflamed environment. So we give pre-probiotics to these patients. We give, post like embryo transfer. We give them either progesterone or down regulation, and then we do the ET along with the probiotic support.
Okay. Thank you.
Ma'am, what you want to say?
I will say that I have met a professor today who's got 10 people working for a PhD under her on endometrial receptivity. But as an old teacher, I wish to tell you, madam, whenever your first presentation into any group, you must show the best out of it. I told you, you have got a skill. You are totally confident, full of control on yourself, knowing so much of material that मेरा बैठकर सारी revision हो गया.
Thank you so
What I
much.
will say as a teacher is that good teacher is
Thank
one
you, what-
who simplifies things for people. आपको सुनने की
Yeah,
बात
thank
शुरू
you so
लगा
much.
बहुत ही बढ़िया है. बाद में सारे लोग कंफ्यूज हो गए. ऐसा कभी नहीं होना चाहिए मैडम. I will say that if you were my student, I will give you good score. But in the end, you confused everybody.
Okay.
So always make a short presentation for 20 minutes. Don't talk of too much of controversy. Whenever there is a controversy, you should put your mind into it. कौन क्या कहता आप 7 मिलीमीटर को भी रिफ्यूट कर रहे हो? आपका एक्सपीरियंस होगा, इतना लंबा चौड़ा एक्सपीरियंस होगा. I have yet to find a pregnancy if endometrium is less than 6-7 millimeter. This is my experience. I have yet to find, in case if there is a fluid and if you do an endometrial transfer, there will never be a pregnancy. You make a sense when you say there is endometrial dating has been as old as 50 years when I was a student. And now if you combine with molecular dating, probably it is going to be as the Brigadier Sharma has said, tomorrow a strip test will be there. You can say that both the things are matching and you transfer. So I find, as an old teacher, I can say that pregnancy rate paane ke liye quality of embryo is the most important. Gets 9 out of 10 marks. Endometrial receptivity is only 10%. आप इसको कितना भी बढ़ा के चढ़ा के बोल दोगे तो 15% हो जाएगा, ज्यादा नहीं होगा. So मेरा आपको I will give you a time of my 1 minute of mine. मैडम मेरे को नूपुर ये बताओ कि आप अपने को समराइज करना चाहोगे तो 1 मिनट में कैसे समराइज करोगे? You've researched everything. You exactly know what the answer is. So I think you will combine myself and Dr. Brigadier Sharma by combining in 1 minute your answer finally. Okay, what do you think is receptivity is all about? And what is your answer, simple answer to 60 people who are watching you?
Ma'am, according to me,
Don't mind what I said.
Ma'am, endometrial receptivity cannot be actually judged with a single marker. And in my patients, I would, combine a lot of factors together, and based on that, I will come to a, conclusion. And I would use the most commonly used, instruments or the gadgets like ultrasound. Will be my first preference, ultrasound, because it's the most commonly used. And in a patient who has not undergone a previous IVF failure or fertility failure, I will not subject that patient to any invasive test as per se. Based on the patient's history, if the patient is obese, I would ask her to make some lifestyle changes, supplement with micronutrients, probiotics, because they are safe. As such, we haven't seen any side effects. And based on her profile, I would like to, improve her outcome. That is my.
Let's hear from Dr. Jyoti. What is her
Dr.
long
Jyoti.
experience and what is her comment in few lines as far the endometrial receptivity is concerned? Dr. Jyoti. And then we will take it from Dr. Aruna Saxena, and I can see Dr. Renu Mishra also here.
As far as the receptivity is concerned, I take, besides the thickness, I usually see for its uniformity, how uniform it is, how smooth it is, whether it is trilaminar or no. Blood flow, I do put in, but blood flow, what I have seen personally, doesn't make much difference. And instead of PI, VFI or whatever, I usually divide the entire endometrium arbitrarily into 4 zones. Zone 1 at the junction of myometrium and endometrium, and zone 4 is the actual endometrial line, the central line. and in between 2 and 3. If you see a blood supply, however small thick vessels are coming till zone 4, then it is definitely very good. Even if it is coming till zone 2 and 3, then also we have seen pregnancies occurring. And broken hai ya smooth hai, homogeneous hai, that really matters. And we have all seen in FET cycles, when we start progesterone, it starts shrinking a little. फिर हमको कई बारी डाउट होता है पहले कितना था और अब कितना हो गया. And we usually do hysteroscopy also for all our patients.
She
And
talked
in
about
our-
compaction.
Yes, that's what it is. It shrinks under the effect of progesterone. And the second thing is we usually do HRT cycles in our center, and natural cycles we only try once we are not very happy with the HRT cycle or repeated IVF failure. And one thing here I would like to share, which I have learned recently from sir, is that that in case we have a failure, 2-3 failures or 1 failure, we treat them for viral endometritis. We have started giving them acyclovir, and before she has a period, we do a biopsy also, that sir has told me, and we especially tell the reproductive pathologist to look for vacuolation. And that vacuolation also, whether it is nuclear, supranuclear, subnuclear, to interpret, all these things are not going to affect much in our treatment. We need to give them probiotics and antibiotics accordingly, but it will help us in counseling the patient कि ये problem थी, इसलिए ऐसा failure हुआ. So,
Dr. Aruna Saxena.
Aruna.
These are all people trained.
Aruna, you are muted.
मैंने ये बात सर से सीखी है.
Ma'am, I would like to share my experience, what I actually do in my practice. See, ma'am, the only most reliable criteria for the endometrial receptivity is endometrial thickness. What I do, as Nupur rightly said, any endometrium 7 to 10, anything could be receptive or non-receptive. So I usually follow my patient the previous cycle, and if a patient is a thickness of 10 mm say in previous cycle, and when I'm actually transferring the embryo, I will not compromise for 7 and 8 mm. I change the protocol and try to get the maximum endometrial thickness and then do the transfer. It may take 1 or 2 cycles, number 1. Number 2, I definitely look for endometrial peristalsis on the day of transfer. If the endometrial peristaltic movements are more than 3 in 1 minute, I like to put my patient on atoxibin, and in my experience, it helps. And third thing is, about the all said and done, whatever the markers are there, the only treatment is progesterone. So I definitely do a pre-transfer progesterone on the day prior to ET, and if progesterone is less, I like to add progesterone on the day of ET and further, and also I repeat the progesterone on day 6 of the transfer and add progesterone accordingly if required.
Dr. Renu ma'am.
Hello everyone. Hi, I'm sorry I joined almost at the end, so I have not heard all what Nupur said. But coming to endometrium or implantation, I also feel very strongly, as Dr. Sharda ma'am said, that it is majorly the embryo which matters, when there is no poor implantation rather than the endometrium. Endometrium, I know there are a lot of tests, people do ERA, people do a lot of things, but in my own practice, I keep it very simple. I just look at the endometrial thickness. And if the endometrial thickness is good, and if the patient doesn't have, any irregularity of endometrium, then I would go for transfer anything more than 8. And if there is fluid, I've had a few patients which really troubled me with fluid. So obviously you look for hydrosalpinx, you do a hysteroscopy, look for endometritis. Endometritis is a very debatable, very controversial subject. People describe micropolyps and a lot of things. But there is a lot of controversy about the diagnosis itself. But anyway, if you find nothing, you put them on a course of antibiotics, and sometimes it helps. And sometimes if you change the protocol for endometrial preparation, then the fluid doesn't appear. So, endometrial, that way, it is very dicey. Sometimes you find nothing wrong and yet the implantation doesn't occur. But I don't really go for a very, sort of ERA and all. I do it very simply, look at the endometrium, look at the blood flow, and that's it. Because I feel if the embryo is good, it is more likely to implant. If the embryo is poor, then no matter what you do to the endometrium, there will not be implantation. If the ET is very less, that is another problem. You look for adhesions. Sometimes there are no adhesions also. Still the endometrium is very thin. And these are very, very frustrating cases. I have injected PRP, nothing happens. Well, I don't have a long, I can't say that I've done it in 30, 40 cases. I've done only a few cases, but it is still pretty frustrating if the endometrium doesn't grow. Sometimes it doesn't grow. If you look at the patient history, generally you will find curettage or, something which has damaged the endometrium beyond. So, because if it is not damaged, then it will grow, generally. Thank you, ma'am.
So now we will move on to our next session only for 15 minutes.
Dr. Poonam, your comments.
Oh. Ma'am, I would say I am not doing any ERA, etc. I'm not doing anything. I am just what Dr. Renu and you have said. I am doing only ultrasound monitoring and then doing the transfer. And of course, I do see the Doppler findings also. And if the endometrium is less, then naturally we go for hysteroscopy and all, and we cancel the transfer. If it is okay, more than 7, 8, more than 7 or 8 it is, then it's okay, we go for the transfer.
Dr. Anu Chawla, you
All
want to say
HRT
anything?
cycles, no natural cycle. I have never done natural cycle.
Dr. Anu Chawla, you want to make any comment?
I am going to ask from Anu ma'am.
Hello,
Dr.
Dr.
Anu, I will just first introduce her because she has come first time in our forum. She is specialist in reproductive medicine and she is editor in Journal of Human Reproduction, Fertility and Sterility Journal of Bangladesh, and she is North Zone FOGSI coordinator also and additional joint secretary